Hi, this is Emma Sutherland. Join us on FX Medicine next week, where I'll be talking to naturopath Dr. Leah Heckman about the impact of andropause in ageing male patients. Subscribe to us on your favourite podcast app and follow us on social media to make sure you never miss an episode. Hi, and welcome to FX Medicine, where we bring you the latest in evidence-based, integrative, functional and complementary medicine. FX Medicine acknowledges the traditional custodians of country throughout Australia where we live and work, and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. With us today is Ananda Mani, who is an experienced naturopath and nutritionist helping people in both clinical practice and as a lecturer at Torrens University. Ananda works by treating a wide range of health conditions, but she has a special interest in helping problematic skin conditions such as rosacea, psoriasis, acne and eczema, as well as helping people with chronic pain. Her expertise in treating skin conditions comes from personally experiencing adult breakouts and also having chemically sensitive skin throughout her 20s. Ananda has a lot of experience in treating the tricky skin condition rosacea, which is what we will be discussing today. Welcome to FX Medicine, Ananda. Thank you so much for being with us today.
Thanks, Emma. I'm really looking forward to talking about rosacea today, and it's actually part of my journey, my health journey, so it's a topic that is of keen interest to me.
Near and dear to your heart, which is so beautiful because it gives you that authenticity in this space.
Yeah, absolutely.
Now, rosacea is most common in women who are fair-skinned and between the ages of 35 to 50, and because it affects the face, it can have a profoundly negative impact on a woman's quality of life, her self-esteem and her well-being. Now, I'm sure we have all had a patient in clinic with this tricky skin condition, and it's overwhelming to know how to treat it effectively. You know, patients are often told it's a condition of unknown cause and there's no cure, only management. But this leads to patients feeling like their health is beyond their control and consequently they're disempowered in their quest for clear skin. Now, in a recent systematic review, the global prevalence of rosacea was estimated at 5.5% of the adult population, but really, in researching this episode, many other reviews stated that it was up to 10% prevalence. So, Ananda, what exactly is rosacea? What is the pathophysiology involved and what are the key ways it presents? Let's hit the ground running with the basics.
Okay, great. And that statistical research is interesting because it is higher in some countries, like Sweden had that 10% prevalence. So I find that interesting, and maybe that links into or with some of the triggers that I'll talk about. But first, yes, what is rosacea? Well, it's a chronic inflammatory disease of the skin, and the areas of the skin that are predominantly affected are in the central face. And this typically presents with flushing, persistent erythema or redness. There's pustules and papules. And, look, I love this word because I'm just going to try not to trip up, but telangiectasia every time. So that's abnormal dilation of the capillaries or venules under the skin. So you see those dark and enlarged capillaries.
Right.
There's also secondary features. So the skin can be burning or stinging. It can look dry or rough in appearance. There can be skin changes, and we see thickened skin with enlarged pores or an irregular surface. And the eyes can be involved, so you can actually have ocular rosacea as well. And there's quite a few known triggers that result in that blushing, flushing effect. And that's the effect that plays the vital role in rosacea development. And so primary triggers are things like sun exposure and UV exposure, and that's in up to 81% of people presenting with rosacea. They are triggered by sun exposure. But then there's also heat sensitivity. So that can be, with exercise as your body heats up, or in hot weather and hot baths. And I know for me, any kind of warm, stuffy environment used to be a trigger, or wearing like a roll neck, like skivvies. It just heated me up and my face would then flush and blush. There was medications such as nasal or topical steroids. And there's a big neurovascular component, so sensitivity from stress or hormones. That, and that might be emotional stress. There's certain foods or beverages such as alcohol and spicy foods are triggers, and I'm sure we'll go into detail on those later. And then also a combination of poor sleep and stress. So it was a very individual presentation, and people will be triggered by several different things. As I said, probably the most two common are sun exposure and emotional stress.
And both of those are just so hard to avoid, aren't they?
Absolutely, yeah. And, a combination of both of those, and you could have someone flushing and blushing on a regular basis.
Exactly. And what's going on, with the pathophysiology involved in rosacea? What's actually going on under the surface?
Well, it's, as everything, it's complex, and it involves a variety of factors. Those factors trigger both vascular and inflammatory responses. So there's some genetics there, and that's not clear-cut, but there's also neurogenic dysregulation, immune system dysregulation. There's the potential for skin infections or skin, maybe even just overgrowth of commensals, but creating a super antigen. Whenever these kind of processes happen in the skin, there's also barrier function impairment and an inflammatory response. So firstly, with neurovascular, there are alterations in vascular responses and the blood flow to the skin. And this leads to to the easier and more prolonged flushing in response to heat. But there's also an oral thermal flushing response, and that's at hot foods, like temperature hot, so a hot beverage or, a cup of tea or coffee. This altered blood flow occurs more in the affected and inflamed areas of the face. So you might get flushing across the cheeks and nose, but other areas of the face may not be as flushed. And a key driver of this process is the activation of transient receptor potential channels. And they're a large family of non-selective calcium permeable channels, and they're expressed in the cells of the skin, so keratinocytes, melanocytes, immune cells, and the sensory neurons. And in rosacea, there's two of these channels, TRPV1 and TRPA1, and they activate those sensory nerve endings in response to, for example, alcohol or spices or temperature changes. And that leads to the release of vasoactive neuropeptides such as substance P and calcitonin gene-related peptide. And then those neuropeptides cause that inflammatory response of the skin and vessels, and they activate mast cells, macrophages, and other immune cells within the skin. And it is this increased and prolonged expression of those transient receptor potential channels in rosacea patients that results in the facial flushing and dysregulation of the vascularity and neurogenic inflammation. And that's that key factor in the development of the fixed changes. So, there's this propensity, there's more flushing and blushing, and eventually the vascularity the vasculature starts to change and become fixed, which causes persistent erythemia. And there's those larger vessels or dilated vessels in the skin and the dilation of the capillaries. So that's one key process. And the thought is, and it's not clear-cut because there's never a linear process here, but that flushing, blushing propensity is what almost kicks it off. But then, of course, the immune system gets involved, as it always does. And there's dysregulation of both the innate and adaptive arms. And with the innate immune system, the augmentation in those processes leads to upregulation of the cathelicidin pathway, and then that leads to downstream inflammatory and phytochemical cascades. And I'll talk to that now. In particular, in rosacea, there's higher levels of toll-like 2 receptors, and I kind of think that these are akin to security cameras with a very long memory, like a danger recognition pathway. And so in response to a trigger, whatever that might be, UV exposure or spices, there's this augmented danger recognition in response to that trigger, and its signalling is involved in the key inflammatory pathways which drive rosacea. And once that inflammatory pathway is triggered by the toll-like receptor, there's an upregulation and a release of, there's this chemical soup that gets involved. So there's proteolytic enzymes such as matrix, metalloproteinase, in particular 9, and kallikrein-related peptidase 5. And these in turn activate that cathelicidin pathway and its related peptide LL37. And that's, one of the key inflammatory signals and acts as an angiogenic factor, stimulating the vasoactive endothelial growth factor, so VEGF factor. And then we start to see, there's an immune driver as part of those vascular changes as well as a neurogenic pathway. And that inflammation becomes persistent again, and we start to see, an inflammatory cascade in the skin that is maintaining those changes.
It's so complex, and it's kind of fascinating because it all is feeding each other into this big loop of inflammation that just seems to become more and more perpetuated. One study I read showed that people with rosacea, specifically women though, had a high incidence of autoimmune conditions such as type 1 diabetes, celiac and rheumatoid arthritis. So is rosacea an autoimmune disease or not? I mean, I'm confused.
Well, I think it's a common comorbidity, but there are other common comorbidities such as gastrointestinal, cardiovascular and mood disorders. So it may just be that it is a comorbidity. But there are some shared associations between the genes that encode the HLA variants that code for rosacea and diseases such as, you mentioned celiac disease and type 1 diabetes, and there's a number of others. So there's some shared genetic pathways, but I think at this stage the evidence doesn't suggest that it is an autoimmune condition. Okay. But there is an overlap in some of the key drivers. So there's some common factors such as microbiota imbalance and the specific role of the immune system in tolerance, immune dysregulation, inflammation and stress. But those are common to the other comorbidities too. So I think that there's probably common factors between autoimmune conditions and rosacea, but there's also unique features of individual conditions. So I think, maybe we'll see that there is later on, but at this stage there's not enough evidence to suggest that.
Okay, all right. Thank you for clearing that up for me once and for all. What biomarkers can we actually utilise to diagnose rosacea though? And what do you consider to be key differentials between rosacea and other skin conditions, things like acne or eczema?
Yeah, because it is interesting. A red rash doesn't always indicate rosacea. And there's a number of other presentations, as you say, that it can be confused with. But I will say in terms of biomarkers, there's no histological or serological markers that indicate the presence of rosacea. It's done by clinical examination and medical history. Okay. So it is actually, using those. I mean, and usually a patient will come with a diagnosis of rosacea, so it's not something that we do as naturopaths and nutritionists, but there are differential markers. So, for example, acne has comedones and pustules and there may be red skin, but it doesn't include that easy flushing, burning or stinging sensations or the changes in the blood vessels. And rosacea has pustules but no comedones. The tricky thing with both acne and rosacea is that they can both occur at the same time, and that just complicates matters.
Yeah.
And there's other conditions such as seborrheic dermatitis and perioral dermatitis that also overlap, and they may have similar areas of redness, but there'll be differentials. Like seborrheic dermatitis, again, no pustules of rosacea and no flushing, and same with perioral dermatitis. Flushing's not common, and it's got a more the presentation of perioral dermatitis is around the mouth or in the nasolabial folds, not centrally as with rosacea. So there are markers that kind of tell us that it's a rosacea picture rather than some of those other conditions.
Okay, and it sounds like a couple of those key differential markers are the flushing and the central location of the flushing.
Yeah, absolutely.
Yeah, okay, fantastic. And with the drivers for rosacea, what do you think helps it or causes it to kick off during the key ages of 35 to 50? And why are women more affected than men? What's going on here?
So I'll talk about the key ages, and I think that rosacea is a condition that progressively gets worse across time.
Okay.
So you might have someone, and I was a bit like this. I stopped it in its tracks, or I like to think that I did, but that I started with the really flushing, blushing propensity and then started to get more persistent redness or erythema. And if you say that is a gradual process that occurs over time, and then there's, further chronicity that occurs, it may not be that until 35 or 50 that we start to see the full presentation of rosacea.
Okay.
But the other things, there are other things that impact, and why more women than men. I think sex hormones play a role. They have a direct impact on skin cell receptors, and any imbalance or excess can influence skin pathology as well as immune function. And in rosacea in particular, it's more strongly associated with menopause and low levels of estrogen. And they can promote that shift towards T helper 1 status in the immune system and the increases in TNF alpha and natural killer cells. And some of those processes might drive inflammatory processes in the skin. They can't find a specific link between hot flushes as part of the picture. Okay. But again, it might just be that gradual contribution to the flushing blushing effect, because hot flushes don't necessarily you don't specifically see that in just the face. It's a full body experience. But women also tend to have less skin hydration and greater transepidermal water loss, and also skin thickness losses with hormonal changes. And if we say those hormonal changes aren't just happening at menopause, there's a up to 10 years lead up of a change of hormonal factors. So those may predispose them to skin barrier dysfunction and allow, for example, skin microbial shifts or barrier dysfunction. It's linked with a greater predisposition to inflammation and sensitivity. So it might be those factors that we start to see this gradual onset of rosacea, and then it's more likely to be prevalent in women than men.
Yeah, I really like that little insight there around the ages, because if I think about it, I do have patients that are younger than 35 and, they do often come to their appointment looking a little flushed, and it could just be that we just pass it off as something else until then it gets to the point where we just can't ignore it anymore. So I really like that insight. And I feel for women, this change in sex hormones can really promote that shift to the pro-inflammatory processes, and then you've got less skin hydration, you've got thinner skin, and you get skin microbial shifts and skin barrier changes. It seems like almost the perfect storm, doesn't it?
Yes, it does. And look, we know that as we head with those hormonal changes and women heading into menopause, there are other inflammatory shifts. You see it in joint changes, and so why not skin, basically?
Yeah, exactly. Now, for a patient, can you outline the medical treatment that's usually offered to patients so we know?
Yeah, often it's topical.
Okay.
But it depends on the subtype. So if it's just flushing, blushing, they might have, topical agents such as azelaic acid or oral beta blockers to reduce the emotional component of that flushing, blushing. With the erythromatogenia.
That one.
I said that I'm going to be blocked by that.
Yeah.
With the first subtype, where you get the flushing and the persistent flushing or persistent redness and the changes in the blood vessel, they might use Flagyl, and that can be seen to reduce inflammation. There's also alpha adrenergic agonists and to reduce sympathetic drive. Okay. And then with each one, progressive stages is different, slightly different approaches. So papulopustular rosacea, they might use those topicals. They also might use ivermectin or other oral antibiotics. And then with where you see that thickening and changes in the density of the skin and more scar tissue in the phytomatous rosacea, they might use things like isotretinoin or laser.
Okay.
And then for oral rosacea, with its severe, they'll consider oral or local antibiotic therapy. So it depends on the subtype. There's a lot of more topical approaches to rosacea that tend to be offered, such as niacinamide and, as I said, azelaic acid, isotretinoin. So, yes.
Yeah, and look,
it's not a lot.
Yes, exactly. I was just about to say, my experience is not vast in this space, but what I have noticed is a theme of treatment failure, unfortunately. So we will be diving into your ideas on treatment, but I wanted to talk about a population-based cohort study. It was on 50,000 Danish patients with rosacea and the prevalence of celiac disease, Crohn's disease, ulcerative colitis, small intestinal bacterial overgrowth, and irritable bowel syndrome were all significantly higher among patients with rosacea compared to controls. Now, this points to the skin-gut axis, and I do just want to press pause so we can deep dive in here. A study evaluating the role of small intestinal bacterial overgrowth in patients with rosacea demonstrated that eradication of SIBO with rifaximin resulted in complete resolution of rosacea in the vast majority of patients.
Yep.
So let's talk about this. Can you discuss with us, what is the mechanism of action between SIBO, rosacea, and medications like rifaximin? How is this working here?
Yeah, absolutely. So I will say, firstly, with SIBO, there is found to be a higher prevalence in rosacea patients than controls. But as you say, there's a number of gut conditions that are associated with rosacea. And I think, I'll look at it from a number of different angles. If we have a dysbiotic state, and fundamentally that's what SIBO is, there can lead to a compromised intestinal mucosal layer and impaired epithelial-type junctions. And then we see this kind of worsening intestinal barrier function and intestinal permeability. So that allows things that should stay in the gut to move into the bloodstream. So we see the translocation of bacteria or harmful compounds of bacterial origin. They're kind of spilling over into the bloodstream. And those spillover products, if you like, may influence the immune system. We see this in other conditions. We see a hyperresponsiveness of B cells and impaired differentiation of T cells. And so those dysbiotic bacteria or bacterial compounds, along with altered immune cells, can reach the skin from the bloodstream. So they can actually directly impact skin physiology, pathology, and immune responses in the skin. And then we kick off local skin immunity and local skin inflammation. And, if we just, again, think about SIBO, it's been linked with high levels of inflammatory cytokines, including TNF-alpha, which is seen to be something that contributes to rosacea as well. But also, in dysbiotic guts, there is a less production of beneficial, say, short-chain fatty acids such as butyrate. And, if we think about just butyrate, it has this anti-inflammatory effect because it suppresses immune responses by inhibiting proliferation and migration and inhibiting cytokine production by those inflammatory cells. So we've got more potential for inflammatory drivers from those bacterial and bacterial byproducts in the immune system, but also less capacity to dampen that down. And if we think about the pathophysiology of rosacea, it involves activation of the skin, the immune system, and the nervous system in response to physical, chemical, or biological triggers. And so these gut dysbiosis-driven changes could lead to that progression or even just increased severity and flare-ups or sustained symptomology. So it might not be that they're a primary trigger or primary driver of the condition. It may be or it may not be. It could all just be that they increase severity and aggravate the condition. So we just don't know yet.
Yeah, like most things, we just don't know enough yet. But I love those insights around the dysbiotic state. And truly, we really just need to work on the gut, don't we? The impaired gut lining, the increase in intestinal permeability, the translocation of bacteria into the bloodstream, resulting in localized skin inflammation, while at the same time having less production of beneficial and protective compounds like butyrate that are anti-inflammatory. So I feel like that's a really good insight on that front. But what about rosacea and Helicobacter pylori? So studies have found that H. pylori infection is associated with the occurrence of rosacea. What do you see clinically in that space?
Well, from a research perspective, it's unclear.
Okay.
But I mean, I think that I'm going to look for any history of gut overgrowth or dysbiosis, whether it be, Helicobacter pylori or SIBO. But it is unclear, but it's long been suspected because there's a high prevalence of seropositivity in rosacea populations. So is it a smoking gun? So there is, but there's conflicting evidence of its role, and the pathogenic link is difficult to establish because antibiotics independently are helpful for both conditions. So if you're treating H. pylori, maybe you'll just see a dampening down in rosacea because of the antibiotic effect and vice versa. But there are some mechanisms that have been proposed. So Helicobacter pylori drives increased reactive oxygen species and inflammation in the gut. And among those reactive oxygen species is nitric oxide. And that can specifically induce intestinal mucosal inflammation, but also it's got a big role in altering the physiological processes in the skin, driving vasodilation, inflammation, and immune changes. So we see that leading to those clinical manifestations of flushing and erythema. And that's what they think one of the predominant roles of Helicobacter pylori is, if it is a factor. And I think it's probably likely. And also it is, it can drive, H. pylori can drive pro-inflammatory cytokines, TNF-alpha, interleukin-8. And again, you can see that gastric mucosal inflammation, intestinal permeability, and a spillover effect that I talked about before with SIBO. So we might have a number of mechanisms with H. pylori.
It seems there's a lot of commonalities between the two. And I think it's just a question to make sure that you do in your case taking that, have you ever experienced Helicobacter pylori? Have you been diagnosed with it? Have you been treated for it? So a really nice addition there if you're not already doing that. Now, I want to shift the focus to holistic treatment for rosacea. Can you give us a bit of an overview of specific goals of treatment that we should be aiming for?
Yes. So I think the first and most obvious one is avoid known triggers where you can. So be it UV exposure, temperature changes, and alcohol, for example, are the most common triggers apart from emotional stress. But that will be individual. So you just work out what the triggers are. And usually a patient will come to you and they say, I know these are my triggers and I already avoid them. But if they haven't, some discussion around that. I think the second, there's some key priorities here. Support vascular integrity. So stabilise and support the blood vessels in the skin, and reduce inflammation and immune dysregulation. And those, I'd say, would be my top three. But then, of course, rule out Helicobacter pylori or SIBO or other gastrointestinal issues. But if they're present, treat them. And generally support a healthy skin and gut microbiome. Probably what I didn't mention before is, in addition to gut microbiome changes, there's often skin microbiome changes. And wherever there's skin barrier dysfunction, there's going to be changes in the skin microbiome. And so you can even consider antimicrobial strategies for the skin microbiome. Many of those are topical, but, there are some key herbs that may assist with that, or key strategies that might assist with that. I think support skin barrier function. And then there's that trail of other things like eye health, stress management if identified, hormonal changes if identified. But really addressing the key drivers, so inflammation, immune dysregulation, and vascular integrity and barrier function are those key four that need to be addressed.
And when we're looking at vascular integrity, what are your go-tos in this space?
Yeah, so I love a couple of things. One is green tea or sorry, I'm crashing words today.
That one, that acid.
EGCG.
Yeah, got you.
And that is really useful topically.
Lovely.
So there's some research at around 2.5% of EGCG. It can reduce the redness, but also the blood vessel changes. It's got so many impacts to the skin. It's antioxidant, immunomodulatory, photoprotective, anti-angiogenic and anti-inflammatory. And it suppresses that VEGF pathway. So I think I often will talk about holistic treatment and, internal, but in this case, I'm also going to really emphasise that some of the topical strategies that we use can be important. And I describe this to my patients. It's like we can put in supplements and we want them to go to the skin, but the body does what the body does with those supplements. And often we have to get some sustained higher doses or higher therapeutic doses to really meet the needs of all the critical organs like the brain and the heart and liver and everything else before it gets to the skin. So I like to, use oral treatments as well as topical treatments where I can.
Yeah, I just wanted to dive into, vascular integrity, and you said the green tea, which sounds like it's ticking every box, but using it topically, which I was not aware of.
I mean, I'd also use it orally. Depending on whether hot drinks are an issue, they could have some green tea, iced green tea or just cooled green tea. And I will often get patients to make up a spritzer of green tea, and put a couple of tea bags and steep them for 5 minutes and then pour it into a spritzer and put it in the fridge. And that will last up to a week, and then I'd make a new batch, but spray it on their face whenever it feels hot or inflamed.
Yeah, great. I love that. And anything else that you use to support the vascular integrity side of things?
I do like Centella asiatica, and there has been, again, some research in the topical space, but I often will use it as part of a mix, like a herbal liquid mix, to support the vasculature of the skin and skin health generally.
Beautiful. And then your go-tos in relation to inflammation?
Well, I don't know if I mentioned this. I think I briefly mentioned mast cells, but there is a big positive feedback loop with mast cells because they are producers of cathelicidin and then the LL37, which is one of the key inflammatory drivers.
Okay.
And then, of course, that LL37 triggers more mast cell degranulation. So it's this positive feedback loop. So I do like quercetin in this space and Baikal Skullcap, just to reduce mast cell activation and cathelicidin release and therefore inflammatory processes. And vitamin D is also a regulator of cathelicidin expression. So quercetin, Baikal Skullcap, omega-3, and it also can help reduce the risk of progression to ocular rosacea.
Okay.
So I like those. But then, I've used SPMs and a bit of curcumin, particularly if I'm multitasking with other conditions,
Which is often the case. It's often the case, yes.
And another big one, which I think is quite specific to rosacea, is niacinamide.
Okay, tell us more.
And while it's not a direct anti-inflammatory internally, it is one topically, and both niacinamide cream and oral dosing have showed benefit. And so there's some of an anti-inflammatory response there, but I think the big thing here is it improves skin barrier function. And then by improving skin barrier function, will dampen down inflammatory processes.
I really like the coming from the outside and the inside, but in a very strategic way, Ananda.
Yeah, thanks. It was probably through my own experience that I learned that. I was doing a lot of oral support for the skin from the inside out, but then had to find things that would actually just dampen down redness and inflammation, so I didn't have to walk around with makeup on all the time.
Yeah.
That was for my own sense of self-worth, but, There is another study which I found quite interesting that I will just mention, and that was it's a 2008 study, which found that combination of St Mary's thistle and MSM, methanol sulfamethane, and that was shown to have a direct modulating action on cytokines and inflammatory responses. So along with some of green tea and Centella asiatica, St Mary's thistle is one that I will really frequently use in the management of rosacea because of that research, and it led to significant reductions in papule count, in redness and stinging and itch scores.
Okay.
So I'm a big fan of that and have seen good outcomes Well, not just with St Mary's Thistle, but with a combination of things.
Yeah, it sounds like the liquid herbs really get a run at your clinic, Ananda.
Yeah, they do.
Now, you've mentioned some foods to stay away from in the triggers, but do you find any particular foods that are beneficial for patients to be adding into their diet from that food as medicine aspect?
Yeah, yes, but I probably just take a more general anti-inflammatory approach, dietary approach, because, you know, what it's shown is that those trigger foods, and then there's also diets that contain a large amount of fatty foods show positive correlations with rosacea, and that's possibly due to their role in chronic inflammation. So a general anti-inflammatory dietary approach. Sometimes I use a lower histamine approach, but that just depends on what their triggers are. But I'll include really specifically foods that support a healthy microbiome and then foods that support skin health. And in the research, it's the red, yellow, green and orange pigmented fruit and vegetables that really support skin health. And they think that's around carotenoids and photoprotection. It's because the more carotenoids there are in the skin, the greater the photoprotection you have in your skin. But then I just kind of laugh at myself because I go red, yellow, green and orange. But then when I couple this with the foods that support a healthy microbiome, like those polyphenols, which are purple, dark red, black and brown, I'm like, yeah, you may as well just get them to eat the rainbow.
Exactly. I was just thinking the same thing. We can go back to that easy tenet for patients to remember and not make it so complicated.
Yeah, absolutely. But it is an inflammatory condition, so starting with that as a dietary approach I think is pretty important. And then even I don't talk about absolutes with my patients, and I'm really careful around, you know, restricting foods too much. So like a crowding out approach or instead of a cutting out approach. And I just tend to say, okay, if we can get 80 or 85 or, you know, increase their kind of total percentage of the overall anti-inflammatory diet, we start to get to this tipping point where it does make inroads and starts to decrease inflammation generally.
I love that. And you mentioned before around short-chain fatty acids, but I wanted to get your opinion on prebiotics. Which prebiotics do you recommend if you do? And can you tell us the dose, the duration, and how long is it going to take until a patient starts seeing some improvements?
Oh, I hate to be disappointing in this space, but I haven't seen any specific research looking at the role of prebiotics. It doesn't mean that I don't use them, but there's none that are in rosacea specifically. There's more in acne, and that's more around probiotics.
Yes.
But I think we can probably assume they have a positive effect because of the promotion of the short-chain fatty acids. I use them all in my clinic. I use partially hydrolyzed guar gum, GOS, inulin and lactulose, and it all just depends on the clinical presentation of the patient or if I've done any things like GI mapping, what are the specific indicated prebiotics to support the growth of probiotics or of their native populations. So, yes, I use them. No, there's nothing that's rosacea specific, but I think it's more individual approaches.
Yeah, and I definitely think skewing to a more anti-inflammatory profile is going to be the key thing to be aiming for here. But what about the role of probiotics? Because I read about the strain Lactobacillus paracasei, which inhibits substance P-induced skin inflammation. What do you think of probiotics in this space for rosacea?
Yeah, I'm a big fan of specific probiotics rather than just broad spectrum use of probiotics. So as in, I tend not to say, well, here's a probiotic that's got, 10 different strains, use that. I'm more likely to go, here's a probiotic that's got a higher, amount of Lactobacillus paracasei, we'll go with this one.
Yeah.
And there's some other research on the E. coli missile, that one as well, and a few other bits and pieces. Often that research is quite, like they might have done one paper, but there's not the depth of research. That's okay. It doesn't stop me using them because I think probiotics generally reduce inflammation in the skin, and they do that by regulating inflammatory cytokines and activating T regulatory cells of some of the suspected mechanisms, but they also increase ceramide production in the skin.
Okay.
And so have that strengthening barrier function effect as well. So I'm more, as I said, more likely to go with the Lactobacillus paracasei than the general one, but I will use that where I think it's indicated.
Yeah, and I love your approach of being strain specific. It's very respectful towards the strains of using them in that way. Now, anything else around naturopathic treatment for rosacea? I know there's a big trend of beauty from within, so I'd love to know your thoughts on ingestibles like collagen or zinc. Do we use them? Do we not use them? What are your thoughts?
Yes, absolutely. I think zinc, and there's research in zinc, it shows that it can reduce the incidence of inflammatory lesions and papules about over a 3-month period. So I use zinc in a lot of skin conditions. It's got so many various different effects in the skin.
Okay.
And collagen I like, but I would use collagen where I think there's where the skin's dry and sensitive. Because dry, sensitive skin is easily inflamed and it's more likely then to trigger those rosacea processes. So if I perceive that it's just the skin's not holding water or there's bigger transepidermal water loss, that's when I'd use collagen because it does increase the water holding capacity of the skin.
Yeah, I love that insight. And with your zinc, Ananda, what kind of dosage are you using?
Well, look, the research used zinc sulfate at 100 milligrams 3 times a day, and I think that's a pretty hefty dose and also not an ideal form.
No.
So I'm more likely to use another standard zinc.
Citrate.
Yes, or an amino acid chelate form of zinc. Yeah. And, between 25 and 50 milligrams. If I do go to that 50 milligrams a day, it'll be shorter term and then sustain with about a 25 milligram zinc dose. But not forever and ever because, zinc dosing can throw out your other minerals. So, again, I'm conscious that I want to use it as a tool to elicit change in the skin state and reduce inflammation and then bring in food sources of zinc when we've seen enough benefit from using zinc.
I love that. Food is medicine. Once again, always a good baseline, isn't it? Now, my last question for you, Ananda, is do you see any big mistakes that we tend to make when we tackle rosacea as clinicians?
I think probably something that I haven't talked about strongly is that we can see some subtyping and with rosacea because there's 4 different subtypes and there are some drivers those subtypes are also based on perhaps progression and severity of rosacea. So, for example, with the papulopustular subtype, you see a greater incidence of Dermadex and more SIBO in that subtype. So I guess the thing that I would say is we can't treat all rosacea the same. And even though it's a progressive condition, we look at where that patient is at and treat them according to their presentation. Is it predominantly flushing, blushing, and can we do something about supporting those blood vessels and reducing the triggers? Is it where there's actual changes in the blood vessels and a persistent state of erythemia? Or are they getting progressive changes and do we need to take a broader look? So check for everything in your assessment that I've discussed, but then really target your treatment to what's presenting in that patient.
And as always, patients are complex, they're multifactorial, but I think the insights that you've shared with us today are going to make it a little bit more easier for us to tackle those tricky rosacea cases that come walking in our door. I'm going to have a goal. I've just made a goal now that for each rosacea patient I treat, the goal would be that she feels comfortable going and doing her shopping makeup free.
Yeah, great.
Thank you.
Good goal.
It is. Thank you so much for joining us today, Ananda. I really appreciate your time.
Thanks, Emma, for having me. It was great.
Thank you, everyone, for listening today. Don't forget that you can find all the show notes, transcripts, and other resources from today's episode on the FX Medicine website. I'm Emma Sutherland. Thanks for joining us, and we'll see you next time.
Enjoyed this episode? Subscribe to FX Medicine by Bioceuticals on YouTube by pressing our logo. You can also head to bioceuticals.com.au/education for more healthcare professional resources.